Welcome to today's video on muscle conditioning and its role in injury prevention and rehabilitation. Whether you are recovering from an injury or aiming to improve performance, understanding key components like muscle activation, strength, power, and endurance is essential. Let's start with key components of muscle conditioning: muscle activation and motor control, muscle strength, muscle power, and muscle endurance. At the core of muscle conditioning is muscle activation and motor control. These are critical for coordinated and skilled movements. They integrate perception, motor planning, execution, and feedback. When muscles are activated properly, they work together in smooth, coordinated way. But injury-induced pain and swelling can interfere with this, leading to poor movement patterns and increasing the risk for further joint injury. Muscle activation becomes even more important when it comes to injury prevention and rehabilitation. Passive structures like ligaments can stabilize joints under low loads, but once the load increases, muscle must take over. Injuries in areas like shoulders, knees, pelvis, and the low back require motor control focused rehabilitation. For example, in anterior cruciate ligament injuries, quadriceps inhibition is common, highlighting the need for targeted activation to restore stability and prevent further damage. When rehabilitating injured muscles, we focus on isolated isometric contractions to activate inhibited muscles, such as after an ACL surgery. Differentiating between local and global muscles, where local muscles stabilize joints and global muscles produces torque. Balancing both is key for functional movement. Correcting abnormal movement patterns by breaking them down into components. This may involve strengthening weak muscles, stretching tight muscles, and improving coordination through specific exercises. We use several facilitation techniques to improve muscle activation. Palpation and biofeedback help us feel and track muscle engagement. Mirrors and verbal cues guide the patient to refine their movements. By starting with unresisted movement in supportive positions and gradually progressing to functional exercises, we help the patient regain muscle control and awareness. Today we will explore how motor control plays a vital role in a recovery from chronic shoulder impingement. Meet Emma, a 20-year-old volleyball player dealing with persistent shoulder pain that worsened over time. Her sharp pain during spikes, now even affecting daily movements, brought her to the clinic. Key findings during assessment is divided into three parts: observed dysfunction, underlying cause, and impact. Excessive humeral translation and pain during overhead movements. Poor scapular stability, including anterior tilt and limited upward rotation. Weak scapular stabilizers, specifically the lower trapezius and serratus anterior. Over-reliance on compensatory muscles, leading to altered movement patterns. Impaired motor control resulted in abnormal joint mechanics, increasing strain on the rotator cuff and shoulder joint. Rehabilitation plan is divided into three phases. Phase 1 is muscle activation. The goal is to restore scapular stability and motor control through targeted activation exercises. For example, scapular retraction with TheraBand. Focus will be on activating the lower trapezius and rhomboids. Phase 2 is motor control progression. Goal is to improve scapular stability during dynamic movements to improve control under load. For example, stability ball push-ups. Focus is on engaging scapular stabilizers during a functional weight-bearing exercise. Phase 3 is functional reintegration. Goal is to restore pain-free overhead function for sport-specific movements. For example, overhead throw with scapular focus. Focus on translating scapular motor control into functional activity.